Mr. Chairman, the time is up.
Okay, dear colleagues, ladies and gentlemen, welcome you to the APSC Cloud Forum of Cardiovascular Disease Series. Today, we would like to discuss about the issue from the AHA and the TCT 2024, especially focus on the prevention and the intervention. I'm Dr. Chen from the Taipei, Taiwan, and currently I work in the Taipei University Hospital, and my co-chair, Dr. Tomohiko Taniguchi. He is now the assistant director of the Department of Cardiovascular Medicine in Kobe City Medical Center General Hospital in Japan. And at first, I would like to do some innovation introduction. In the 2024 HA and the TCT meeting, innovative late-breaking clinical trials in prevention and interventions are emerging with great attention. Novel lipoprotein small a lowering agents, zerlasiran and mulvalaplin touch the starting line in atherosclerosis cardiovascular disease prevention, but calling repercussions on potential benefit or risk. And another drug, Obicetrapib, a new CETP inhibitor, hit the same challenges in HDL upgrading. And on the other hand, terzapatide and GLP-1 and the GIP dual agonist demonstrated significant benefit in obesity HFpEF, but missing efficacy in all-cause mortality. So interesting, in the early TAVR or TAVR in asymptomatic severe aortic stenosis is showing clear benefit in composite endpoints, leaving the curiosity in how early is early. And the novel Bioadaptor, a new coronary stent with a minimal profile, demonstrated a brilliant outcome in INFINITY-SWEDHEART and paving a new paradigm in coronary implants. Much innovations are coming, but clearly deserve repercussions in depth. So we are very happy today. We have five speakers in this session. Before the talk, I want to do some disclaimer. The contents of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. Any the views and the opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. For the housekeeping, the living streaming contents of this webinar will be made available via APSC Cloud, APSC Facebook, and YouTube pages. So let's start this session. I would like to introduce the first speaker and the first two speakers, and then Professor Tomohiko will introduce the following three speakers. The first speaker is Dr. Amaha Sadi bin Mahmoud Rudi from Malaysia. He is currently the associate professor and consulting cardiologist in the cardiology Department of Medicine, Faculty of Medicine in the University of Malaya in Kuala Lumpur, Malaysia. He will introduce us the phase 2 trials of novel lipoprotein small a lowering agents to lower the atherosclerosis cardiovascular disease risk. Let's welcome Professor Sadi Rudi.
Okay, thank you very much, Mr. Chairman. Can you hear me? Yeah, everybody? Yep,
Yes.
okay. So I'm just gonna share my slides here. All right, so can you see my slide? Yep.
Yes.
Okay, so first of all, thank you very much, APSC, for inviting me to speak on this topic. So I was asked to speak on the two trials on the new Lp(a) lowering agents, which are the zerlasiran and the mulvalaplin. So they are the newcomers, and they may be the new hammer in ASCVD risk reduction. So my name is Shadi, one of the consultant cardiologists from University Malaya Medical Center in Kuala Lumpur. So first of all, some introduction. As we know, I'm sure we all know, Lp(a) is associated with ASCVD and also calcified aortic valve stenosis. By nature, Lp(a) is pro-inflammatory, pro-atherogenic, and pro-thrombosis. And it is thought to be more atherogenic than the common LDL-C. So the level is again determined by genetic. It is determined by the gene LPA, which produces messenger RNA and induce the production of lipoprotein A. So the question is whether Lp(a) is a modifiable risk factor, who would benefit from Lp(a) lowering, and the degree of Lp(a) lowering needed to reduce the cardiovascular events still remain unknown. Also, therapeutic options for patients with elevated Lp(a) are currently very limited. So this is just the basic molecular structure of Lp(a). As you can see on the left side is your normal LDL, and Lp(a) is different from LDL just by having the chain of ApoA, which is attached to the ApoB component of the LDL. So by having this chain, it is more atherogenic than LDL-C itself. And this is a recent trial just published last year, actually earlier this year. It is saying that the atherogenicity of Lp(a) is roughly 6-fold greater than LDL-C. So if you see many practice guidelines in lipid management, Lp(a) is recommended to be screened as a CV risk enhancer. So there are two potential pharmacological ways to reduce Lp(a). As you can see from this diagram taken from JAMA, the first way is to interfere with the mRNA. So by interfering with mRNA, we will reduce the production of ApoA, which is needed to form Lp(a). That's the first way. The second way is to prevent the ApoA from binding to the ApoB component of LDL-C. So there's two ways. One is to, reduce the production. Second is to prevent it from binding to the ApoB. So these are the potential pharmacological ways to reduce Lp(a). The first one is zerlasiran, which is the small interfering RNA to reduce the production of lipoprotein A by degrading the mRNA. The second is mulvalaplin, which blocks the lipoprotein A from binding to ApoB. So we move on first to mulvalaplin. So this is an oral form of small molecule inhibitor therapy. What it does is it prevents binding of ApoA to ApoB component, hence preventing the formation of Lp(a). So it has undergone phase 1 trial, which was published last year in August, and it shows that oral mulvalaplin on a daily basis will reduce Lp(a) up to 65% in 14 days. So this is the phase 1 trial. And based on this trial, they have come out with a phase 2 trial, which was also recently published a month ago in JAMA. So the title of the paper was Oral Mulvalaplin for Lowering Lp(a), a randomized clinical trial. This is a phase 2 placebo-controlled randomized double-blind trial. It was done at 43 sites in Asia, Europe, Brazil, Australia, and the United States. So it included 233 participants with Lp(a) concentration of more than 175 with ASCVD or diabetes or familial hypercholesterolemia. So the exclusion criteria is as follows: uncontrolled diabetes or hypertension, poor kidney function, body mass index of very low or very high, any recent cardiovascular event or surgery in the previous 3 months, and also other condition indicating unstable medical state. So this is the flow chart of the randomized phase 2 trial. They have screened 342 adults with high Lp(a) and high risk of cardiovascular events. Out of the 342, 109 were excluded. So they end up with 233 randomized patients. And these patients were randomized to receive 3 different doses of mulvalaplin and also 1 arm of placebo. And all these patients were followed up for 3 months. So the primary endpoint was percentage change in Lp(a) from baseline to week 12, which is 3 months down the line, compared to placebo. And in this trial, because the aim of mulvalaplin is not to reduce the production of apolipoprotein A, so they had to use a different assay. They used 2 assays actually. The first one was the usual assay used in other trials, which measures apolipoprotein A. And another assay was to measure intact Lp(a). So this is the result. As you can see, mulvalaplin at high dose produces, as expected, the lowest reduction of Lp(a) at 12 months, and the reduction occurs early. By week 4, the reduction is already at more than 80%, and it stabilizes over the period of week 4 until week 12. And this is consistent with the 2 different assays. The more appropriate assay for this study, which was the intact lipoprotein assay, shows greater reduction as compared to the usual apolipoprotein A based assay. So as you can see there, with 220 milligram daily dose and also 60 milligram daily dose, you can have a reduction of more than 80% in Lp(a) beginning from week 4 until week 12. And this is the individual responses to the dosage. Again, this is just to show the consistency of a different dosage, different responses between each individual study patients. And you can see in diagram A, the responses were very consistent. The mulvalaplin dose of 240 being the most potent and the one that produces the largest reduction in Lp(a). What about the safety profile and tolerability? From the publication, it was it was stated that mulvalaplin was very well tolerated with very few serious adverse event related to the investigational product, no dose-dependent adverse events, and no concerning biochemical abnormality. So, however, there were a few study limitations to the trials. The first one was the study duration was only for 12 weeks. So the impact of longer administration on efficacy and safety requires further evaluation. Second, the intact lipoprotein A assay is not available in clinical practice and has not yet been widely evaluated. Also, it is unknown if apolipoprotein A itself, unbound to the complex, the LDL complex, have any biological effect. So we don't know whether this is also atherogenic or not. And the last one is whether LP(a) lowering, of course, this is the most important one, whether LP(a) lowering reduces cardiovascular event, and to which degree of lowering required to produce this meaningful event remains unknown. So I think the number 4, the study limitation number 4, is the most important one. And this, they hope that this will be answered in phase 3 trials with optimum dose and more patients and longer follow-up time. So the second therapeutic option is something called zerlasiran, which is the small interfering RNA. What it does is it degrades the microRNA produced by the LPA, and hence blocking the production of apolipoprotein A. So again, also published on the very same day, on November 18, just a month from now. So it's also a phase 2 trial for placebo-controlled, randomized, and double-blind. It involves 26 sites in Europe and South Africa. Although it has a lower number of patients, it only has 178 patients with stable ASCVD, and also serum LP(a) greater or equal to 125. Again, the exclusion criteria: acute cardiovascular event within the last 3 months, a poor kidney function, and also history of liver disease or moderate to severe heart failure. This is the flow chart. They screened 253 patients, of which 73 were excluded. So they end up with 180 patients, which were randomized to different dosage of zerlasiran. The first one was 450 every 6 months. The second group was 300 milligrams every 4 months. And the third is 300 milligrams every 6 months. And the final group was the placebo group. So this is the result. This is the diagram or the result for 450 milligrams every 6 months. As you can see, similar to mulvalaplin, you get after the first injection, you get a huge reduction, even more than mulvalaplin. This is a median percentage of reduction of more than 90%. Peak at week 4. And then after that, it slowly goes up until week 24, which is at 6 months. And that is when the second injection was given. And the LP(a) level goes down again at 4 weeks after the second injection. And then it goes up again even at week 60, which is 48 months. 48 months after the last injection, the LP(a) was still at around 45-50% reduced from the original reading. What about the 300 milligrams every 4 months? Again, it produces the same pattern. 4 weeks after the injection, it goes down to a very low level, more than 90% reduction. It slowly goes up again. And it was given again at week 4, and it goes down again. And the pattern follows up until week 60. What about the 300 milligram dose? It reduces the LP little a, but not as much as the 450 milligrams dosage. But it also reduces the LP little a significantly, although not as much as the higher dose. And individual response are very consistent, showing the response to each of the dosage. And the waterfall plot here showed consistent effects among patients treated with zerlasiran for each of the dosage group. Safety profile also very good. Safety data showed no serious adverse events related to the study drugs. And limitation of the study. For this study, it was done predominantly in white male participants. So the effect of zerlasiran in other racial and ethnic minority patients needs further study. The study sample was also moderate in size, not so big, not large enough to rule out many uncommon adverse events. And the last one, only 2 doses were administered at 24-week dosing interval. The long-term effects of zerlasiran with repeated dosing remain less certain and must be estimated with modeling rather than observed data. So all in all, the conclusion, mulvalaplin versus zerlasiran, both therapeutic options were shown to be very efficacious in reducing LP little a, at least in a limited follow-up duration. Mulvalaplin offer non-injectable option. It is given as oral tablet, while zerlasiran offers infrequent injectable dosing. Both have shown to be well tolerated without significant safety concerns so far. We will wait for the phase 3 trials for both, which I think are needed for the definite efficacy, safety, and more importantly, whether this is translated into CV outcome benefit. With that, I thank you.
Thank you very much, Dr. Zadi Rudi, for your very informative and detailed talk. Now is the QA. We have 5 minutes for the QA. Is there any question from our colleagues? No, I would like to ask Dr. Rudi.
Okay.
So do you think which one is better and maybe use earlier in the future?
Okay, in terms of efficacy, it seems that the small interfering RNA is more efficacious than the oral form of mulvalaplin. And the option of injectable every 6 months is very attractive, similar to inclisiran in reducing LDL-C. But we will have to wait for the phase 3 trials to be more certain in terms of their definite efficacy and safety.
Yeah, very good. Do you think do you have any information about the potentially price of these 2 drugs?
Oh, the price, I would suspect the injectables would be more expensive compared to the oral form, but I cannot be certain. But I suspect it is the case.
Yeah. And do you know any difference in the effect of these 2 drugs in different patient of different races? For especially such as in is there any difference in effect in Asian versus the European?
Oh yes. As any other lipid reduction, there will be the non-responders And from the mulvalaplin trial, there are 1 or 2 patients who did not respond to the tablet, and similar to the zerlasiran. So I think it's the similar case to um, to inclisiran and evolocumab. There will be some non-responders, but whether it is related to ethnicity, I don't know. I don't know whether it's related to ethnicity, because we know that some ethnic groups has higher LP little a, but whether they will respond in a similar manner as the other ethnic groups, I have no idea.
Okay, the final question. We know that the lipoprotein little a may be some genetic related.
Mm-hmm.
So, do you think we should examine or check the genetic background for these patients before they use to use these drugs?
I don't think there's a need for us to check the genetic background, because the aim is to lower the LP little a anyway, similar to LDLC. But whether we should go down the route of familial hypercholesterolemia with molecular genetic testing and so on, I think there's no indication to do so in LP little a so far, because because it is we don't know, this is not a genetic mutation as in familial hypercholesterolemia. So I think as it is not some mutation, it is, I think there's no need to check for the genetic molecular testing so far, as far as I'm concerned.
Thank you. Is there any questions from our colleague? Okay. If no other questions, I would thanks Professor
Okay,
Tadia.
thank you very much. Thank you very much, everyone.
So I will move to the next talk. The next speaker is Dr. Daniel Louis Vinanuva. I hope I can pronounce it right.
Yeah.
Yeah, from Philippines. Anyway, Dr. Daniel Louis Vinanuva is currently the board of director in Philippine Lipid and Atherosclerosis Society, and he's also the vice president of the Philippine Heart Association in the Southern Tagalog chapter. And he's also the vice chair, Council of Hypertension in the Philippine Heart Association, and currently in Manila, Philippines. Today he will discuss with about the Obicetrapib in the heterozygous familial hypercholesterolemia clinical trials. Let's welcome Dr. Vinanuva.
Thank you, Dr. Chen. You pronounce it correctly.
Thank you.
So I'd like to share my slide, please. Okay. Okay, can you see my slide?
Yes.
Yes.
Okay. So again, good afternoon and thank you for this opportunity. I'm Dr. Daniel Luis Villanueva from the Philippines. And on behalf of the Philippine Heart Association, it's my privilege to be part of this cloud webinar by the APSC. So I have been tasked to discuss with you Obicetrapib in heterozygous familial hypercholesterolemia, and are the CETP inhibitors returning strong. So we'll begin. So I have nothing to disclose with regards to this lecture. So I'll start off my lecture with this slide here, which is very important for us cardiologists, because we know very well that low-density lipoprotein cholesterol is the primary cause of atherosclerotic cardiovascular disease. And the target of many interventions are aimed at reducing your LDL to reduce ASCVD events. And we know very well that a large meta-analysis have already shown that for every 1 millimole reduction in LDL cholesterol is associated with a subsequent 22% reduction in the risk of major cardiovascular events. That's why our treatment guidelines, both from the American Heart Association as well as from the European Society of Cardiology, they advocate for a lower target LDL, especially for high-risk patients. We should target less than 70 milligrams per deciliter, and for very high-risk patients, less than 55 milligrams per deciliter, in combination with a more than or equal to 50% reduction from the baseline LDL. And here in the Philippines and also globally, one of the reasons why ischemic heart disease is still very much burdensome is that we're still unable to target the optimal LDL targets among our patients. If you look at this global study here in the Da Vinci study, only 33% of the patients are able to reach their risk-based LDL goal. And sadly, among these patients who already had an event with an ASCVD event, only 18% are able to reach their LDL target goal. Here in the Philippines, we have a local study here, almost similar result, 33% were able to achieve the risk-based goal. And among those already with an acute coronary syndrome, only a quarter of patients are able to achieve the LDL targets. So this is very sad, considering we already have multiple lipid-lowering therapies available. And if you look at this figure here, this is from a European cohort. Among those high-risk patients, majority of these patients are only on moderate intensity statin therapy. So 1/2 of these high-risk patients are on moderate intensity statin therapy. Only 28% are on high-intensity statin therapy. And if you look at it, we already have the combination therapy, but only less than 10% is receiving ezetimibe. And with the availability of the PCSK9 inhibitors, only 1% were able to be put on PCSK9 inhibitors. So given that the majority of individuals in our clinical practice experience residual risk from the inability to achieve recommended levels of LDL cholesterol, there remains a significant unmet need for therapies that substantially reduce LDL cholesterol and consequent ASCVD risk. So we're after, particularly for medicines that are convenient, that are be able to be given as oral dosing, and with favorable tolerability. So this is where your cholesterol ester transfer proteins or your CETP inhibitors come in. So this was already studied before. The initial development of your CETP inhibitors was motivated by the discovery that humans with genetic CETP deficiency have markedly elevated levels of high-density lipoprotein and reduced levels of LDL. Both combination is a profile that is typically associated with reduced atherosclerosis. And in animal studies, they found out that there was delayed development of atherosclerosis in CETP knockout studies and accelerated atherosclerosis in CETP knock-in models. This was also shown in the Copenhagen City Heart Study, wherein they found 2 common CETP reduced function polymorphisms, both of which were associated with reduced MACE and mortality. So the primary effect of CETP inhibition is a reduced rate of transfer of your cholesterol esters from your HDL into your triglyceride-rich lipoproteins, which are your VLDL as well as your LDL. This leads to an increased content of your cholesterol esters in your HDL and a formation of a larger HDL molecule that is more slowly catabolized than normal. So this is the initial premise for CETP inhibitors. They want to increase the HDL, knowing that it will lower down cardiovascular risk. On the other side of the coin, the cholesterol esters within your TRLs are reduced. So cholesterol esters within your VLDL and your LDL are reduced, and they are more catabolized. Thus, the major impact of your CETP inhibition is an increase in both your HDL cholesterol and a decrease in your non-HDL cholesterol encompassing your triglyceride-rich lipoproteins, including your VLDL and your LDL. So this is why CETP inhibitors were studied before. However, the initial attempts to develop CETP inhibitors were strikingly unsuccessful. So I'd like to show you a bit of history of the CETP inhibitors that were studied in the early 2000s. So in 2006, the first CETP inhibitor was terzapatide. It demonstrated excess mortality in the phase 3 Illuminate trial, which was prematurely terminated. And then when they did the post-hoc analysis, they found out that the mortality was attributed to an increase in aldosterone, which was accompanied by an increase in the systolic blood pressure of the participants, and also hypokalemia. There were also other untoward electrolyte imbalances identified in this study. Hence, it was not continued. Subsequently, in 2012, another CETP inhibitor, which was zerlasiran, failed to show a benefit on cardiovascular mortality in MACE among post-ACS patients. Zerlasiran, interestingly, did not have an effect in LDL cholesterol, although it increased the HDL cholesterol by 31%. Another potent CETP inhibitor was evacetrapib in the Accelerate trial. It also failed to reduce MACE in high-risk secondary prevention patients, despite an increase of your HDL by 133% and a reduction in your LDL cholesterol by 31%. So the trial was terminated prematurely for futility after a median follow-up of 26 months. However, in 2017, outcomes for the anacetrapib trial in the REVEAL trial, which involved 30,000 patients, as secondary prevention on top of high-intensity statin therapy. So they found that anacetrapib reduced the primary composite outcome of coronary death, MI, or coronary revasc, but not overall mortality or cardiovascular death. So the design of the study was an issue with this trial because the baseline mean LDL at that time was very low. It was around 61 milligrams per deciliter for the participants. So the study showed a reduction of 40% for LDL cholesterol and 18% for non-HDL cholesterol. However, despite achieving its primary endpoint, it was considered a failure. So this is where obicetrapib comes in. So obicetrapib is a newer and more potent CETP inhibitor. It's known as TA8995. It's the most polar of all the CETP inhibitors, which improves its binding and specificity, and it can inhibit CETP up to 97%. In this phase 2 study, so this is the study done among patients who are high risk. So it's the ROSE study, the randomized study of obicetrapib as an adjunct to statin therapy, wherein they put the patients either on obicetrapib 5 milligrams and 10 milligrams compared with placebo. All patients were treated with maximally tolerated high-intensity statin for a minimum of 8 weeks, and the baseline pre-treatment LDL was 88 to 95 milligrams per deciliter. So for the results, they found that obicetrapib treatment compared with placebo produced a mean LDL cholesterol reduction of 51% with the 10 milligrams and a 42% reduction with the 5 milligrams versus the placebo. Additionally, ApoB was also reduced by 24.4% and 29.8% with the 10 milligrams. HDL was found to be increased by almost 165% with obicetrapib versus placebo. And then when they looked at adverse events, there was no significant differences in adverse events or off-target effects for obicetrapib versus the placebo. So the ROSE study provided a light in the tunnel for obicetrapib for the CETP inhibitors. That's why it was followed up with the ROSE-2 study, wherein it's a phase 2 clinical trial. They combined obicetrapib with that of ezetimibe 10 milligrams on top of high-intensity statins. So this was among 119 patients for 12 weeks or 84 days. And then they found out that combination therapy of obicetrapib 10 milligrams and ezetimibe for 12 weeks lowered their LDL cholesterol by 63.4%, compared with a 43.5% reduction for monotherapy of obicetrapib 10 milligrams. And this magnitude of reduction in atherogenic lipoproteins is comparable to the addition of a PCSK9 inhibitor to a high-intensity statin. And interestingly, they found out in this trial that 87.1% of patients on combination obicetrapib and ezetimibe, compared with 42.3% patients receiving monotherapy, reached the most stringent LDL goal of less than 55 milligrams per deciliter. So this was also a positive trial. So in summary, the ROSE and the ROSE-2 studies have shown significant reductions in LDL cholesterol and ApoB levels among patients on obicetrapib versus placebo, and even more LDL reduction if you combine a high-dose obicetrapib of 10 milligrams and ezetimibe. It also increased the HDL levels among these high-risk patients. So both the ROSE and the ROSE-2 studies have shown significant reductions among the target LDL and increase in your HDL. Hence, it led to the study of obicetrapib among high-risk individuals, wherein the achievement of very low LDLs is very, very difficult. So for high-risk individuals, such as those with heterozygous familial hypercholesterolemia, for primary prevention, we should target an LDL cholesterol of less than 70 milligrams per deciliter. So there are three phase 3 trials which investigated obicetrapib among these populations. So we have the Brooklyn trial, the Broadway trial, and the Tandem trial. So I'll show you the inclusion criteria for both the Brooklyn and the Broadway trial. So the Brooklyn trial is a placebo-controlled double-blind randomized trial which began in 2022, and it involved patients with history of heterozygous familial hypercholesterolemia and a mean LDL of more than or equal to 70 milligrams per deciliter. And these are patients already on maximally tolerated statins. The Broadway trial are patients with heterozygous familial hypercholesterolemia and a history of ASCVD with a serum LDL cholesterol of more than or equal to 55 milligrams per deciliter on top of maximally tolerated statins. So these are the exclusion criteria of both trials here. So I'd like to show you the study design of both trials. You can see that participants in both trials returned for study visits at approximately 3-month intervals during the treatment period. At visits 2 and 7, the research site staff measured the vital signs as well as their lipid parameters, and also the ApoB lipoprotein A were also measured in the Broadway trial. In a subset of patients in the Broadway trial, ambulatory blood pressure monitoring was conducted at visits 1 and 6 because there was a signal with the first CETP inhibitor, which increased the blood pressure. So they will measure the ABPM during visits 2 and 6. So the trial endpoints for both trials are as follows. So the primary endpoint is a percentage change from baseline of your LDL cholesterol at day 84, and these are the secondary endpoints. Important to note here is that they also included percentage change from baseline to day 84, 180, and 365 for your non-HDL molecules in the Broadway trial. So this is the baseline. These are the baseline characteristics of the study, both for the Brooklyn and the Broadway. Now, they computed for the sample size computation, and for the Broadway, it will require 2,280 participants. For Brooklyn, around 285 participants to provide more than 90% power to detect LDL cholesterol reduction. So you can see here in the Brooklyn trial, majority of the patients are females, while in the Broadway trial, already with ASCVD, majority of the patients are males. And also important to note here with the severe risk factors in the Broadway trial, only 30% have diabetes. So this table shows you the different types of lipid-lowering medications used by the patient. So interestingly, close to 90% of patients in the Broadway trial were taking a statin, but only 79% of these patients were on high-intensity statin therapy. 54% were taking ezetimibe, and only 14% were on a PCSK9 inhibitor. So baseline LDL levels were around 123 milligrams per deciliter in the Brooklyn trial. So clearly shows you that it's really hard to achieve the 70 milligram per deciliter for primary prevention. And interestingly, if you look at the Broadway trial, the mean LDL cholesterol is 98, despite these patients already having a history of ASCVD. So again, it's really hard to achieve that 55 milligrams per deciliter LDL target. So with the results, the primary author here was Dr. Nichols. He presented the study results highlighting the changes in low-density lipoprotein cholesterol reduction of obesity over time. And you can see here that placebo-adjusted LDL cholesterol was decreased by 36.3% with a p-value of 0.001 at day 84 and 41.5% reduction at day 365. Additionally, they found that 34% of your patients achieved also 50% reduction from their baseline LDL cholesterol. And when they also determined that 77% of these patients achieve a 100 milligram per deciliter LDL level, 51% achieve 70 milligrams per deciliter, and 25% achieve 55 milligrams per deciliter target for the very high risk FH patients. So in terms of safety data, they did not find any signals with regards to obicetrapib versus placebo. There were no increase in the blood pressure, no electrolyte imbalances, and no increase in diabetes mellitus. So showing you here the other parameters that was measured in the Brooklyn trial. You can see that placebo-adjusted reductions were observed in your non-HDL parameters up to 37.5%, and ApoB decreased by 24.4%. As expected, your CETP inhibitors raised your HDL level by almost 138.7%. And this is a very good result. Your Lp(a) was also reduced by 45.9% with Obicetrapib. So in terms of adverse effect, there were no difference between your placebo and the Obicetrapib group in terms of new onset diabetes or worsening sugar control or cardiovascular events. Now, with the Broadway trial, so this is among patients who already have a history of ASCVD, they found that Obicetrapib 10 milligrams produced a statistically significant reduction in your LDL cholesterol of as much as 33% at day 84. The Broadway trial also adjudicated MACE, including death, non-fatal MI, non-fatal stroke, and coronary revas as the first 4-point MACE, and they found a 21% reduction in the first 4-point MACE, favoring Obicetrapib 10 milligrams versus placebo. So Obicetrapib was also observed to be well tolerated, with safety data including blood pressure comparable also to placebo. So this is similar with the Brooklyn trial results, and the incidence of your treatment emergent adverse events such as hypokalemia, electrolyte imbalances were not significantly different between the placebo and the Obicetrapib group. So the third trial here is the TANDEM trial. So it's a phase 3 randomized double-blind 4-arm placebo-controlled multi-center study wherein they combine Obicetrapib 10 milligrams and ezetimibe 10 milligrams as a fixed dose combination among patients with heterozygous familial hypercholesterolemia with a history of ASCVD and an LDL that is uncontrolled at level of 70 milligrams per deciliter. So there were 4 arms here, comparing it for 84 days. And then the mean baseline LDL measured for the patients was 97 milligrams per deciliter. So again, it will show you that it's really very hard to achieve the 55 milligram per deciliter target for LDL. So with the results of the TANDEM trial, you can see here at day 84, there was a significant reduction, around 48.6% of your LDL cholesterol with the fixed dose combination of Obicetrapib ezetimibe compared with your monotherapy Obicetrapib and ezetimibe versus your placebo. And if you look at treatment emergent adverse events, it was nothing significant between the 4 groups. So Obicetrapib was also safely tolerated in this study. So to summarize the trials that I've discussed with you, so again, the Brooklyn trial, these are phase 2 trials involving 354 patients for primary prevention of heterozygous familial hypercholesterolemia. They found a 36.3% reduction in LDL at day 84, 41.5% reduction of LDL at day 365. In the Broadway trial, these are patients with ASCVD already. They found a 33% reduction in your LDL cholesterol at day 84. In the TANDEM trial, it's a combination of both your Obicetrapib and ezetimibe among patients with ASCVD also. They found a significant 48.6% reduction in your LDL at day 84. Now, there's an ongoing trial with regards to cardiovascular outcome for Obicetrapib, and this will come out in in year 2026. So we're very excited for this. This will provide us with cardiovascular outcomes with regards to Obicetrapib. So in summary, the phase 2 studies of Obicetrapib demonstrated favorable effects on atherogenic lipid biomarkers, including your non-HDL proteins, ApoB, and your lipoprotein A. Obicetrapib has the potential to become a viable lipid-lowering agent in patients receiving maximally tolerated statin, but not at LDL goal. Ezetimibe is usually the second line in contemporary lipid-lowering therapy. The degree of LDL cholesterol and ApoB reduction achieved with adding ezetimibe to Obicetrapib is much greater than Obicetrapib alone. And while we already have the PCSK9 inhibitors, some patients are unable to use this because of cost or availability. Some patients do not like the injectables also. Thank you very much.
Thank you. Thank you, Dr. Luis Villanova. Thank you for your very detailed and interesting introduction. Is there any question from our colleague?
Yes, there's a question.
Okay, please.
Any age-related adjustment of dosages? Question from Musomo.
Pardon?
Sorry, I did not hear it.
Okay, at the chat room, there's a question. Any age-related adjustment of dosages?
Oh, there were no age-related adjustment in dosages. The mean ages of the patient participants were around 60 years old for both the Brooklyn and the Broadway trials, and they did not pre-specify this as an outcome during the time that they designed the trial. So there were more after of the LDL reduction among this group of patients.
Yeah. Any other question? No, I would ask Dr. Mianua. So, since we have many argument and controversy about the CETP on the drugs in previous clinical trial, so how do you comment on this issue, especially for the potential clinical outcome?
Yeah. So the initial design for the CETP inhibitors was to raise HDL. It was really not to lower down the LDL. But unfortunately, for the first 4 trials, they were not able to see the benefit on overall mortality and CV death despite elevating the HDL. And then in some trials before, they also found that the elevated HDL was also harmful for these patients. So the design of the development of Obicetrapib has shown that in terms of the adverse events seen in the previous trials, such as increase in aldosterone levels manifested by elevated BP, manifested by hypokalemia and electrolyte imbalances, these were not seen in the Brooklyn and the Broadway trials. Although we're still waiting for the CVOT trials for the PREVAIL because it's a longer study duration trial. So we'll see there whether there will be adverse events for this CETP inhibitor. But for the first phase 2, phase 3 trials, it's very promising. We did not appreciate any adverse events.
Yeah. So I think we should now focus on LDL rather than HDL, right?
Yes. So most of the guidelines right now, they're LDL centric. Most of the mortality outcome trials are focused on lowering down the LDL. So the target really is LDL.
Yeah, sure. So, okay. Oh, thank you. Thank you very much. Thank you for your excellent discussion talk. Thank you.
Thank you also.
Okay. So now we should move to the third speaker. Now I will invite Professor Tomohiko Taniguchi to introduce the following speakers. Professor
Sure.
Tomohiko?
Okay. So I am a co-chairperson, Dr. Tomohiko Taniguchi from Kobe City Medical Center General Hospital from Japan. So now let's move on to the next speaker, Dr. Nadia Al-Matrosi. My pronunciation is correct?
Yes, correct.
Thank you. And she is a lead cardiac transplant in Cleveland Clinic, Abu Dhabi, and consultant cardiology and specialize in advanced heart failure and transplant at Cleveland Clinic. And her presentation's title is Terzapatide, GLP-1 and GIP-Jaw receptor agonist in heart failure with preserved EF and obesity. Summit trial, only in heart failure rehospitalization, not all-cause mortality. So,
Yes.
Dr. Nadia, please.
Thank you for the introduction and thank you for the invitation. It's my pleasure today to be with you all in this prestigious conference. So now I can share my presentation. Okay. Can you give me at least access, I think? Okay, then. Can you see my presentation now?
It's in dual screen mode. Would you please end the show and make a one screen because we are watching not the full screen. Try again, please.
Okay. No?
Still, there's a on the up left corner. There's a some it will swap the screen because right
Oh,
now
yeah, this one
yeah,
maybe like this.
maybe
Yeah.
you try another way
No?
because
Okay.
we're
No.
still watching the two slides, which we also watch your next slide. So
Sure, sure. Ah, okay, got you. Okay.
yeah,
Yeah.
there's a switch can change this.
Mm. Mm.
Yeah,
This one. Yeah. Okay.
yeah. Thank you.
Okay. So today, inshallah, I'm going to talk about using of terzapatide receptor agonist in the heart failure with the preserved ejection fraction and obesity. Before I start my presentation, just I want to give some brief about HFpEF. We know all that HFpEF is challenging, particularly in a patient with over signs or symptoms of congestion. It defined that when EF is more than 50% with evidence of spontaneous or an increase in the left ventricular pressure, filling pressure, which characterized by elevated nitric peptide or hemodynamically measurement. It's estimated approximately 50% of a patient with heart failure are classified as HFpEF, and we can see it now in our days in our clinical practice that HFpEF is rising, but although HFrEF is becoming now less or stable, so approximately 50% of this patient are classified as HFpEF, and not all HFpEF will progress to HFrEF. So HFpEF is heterogeneous and clinical syndromes with many phenotype and underlying pathophysiology process of HFpEF differ from HFrEF. So HFpEF have an increased rate of morbidity and mortality compared with a patient without heart failure. However, therapeutic intervention are available to reduce the symptoms and improve functional status and the quality of life and to reduce a hospital admission rate. There are multiple risk factors that can cause HFpEF: aging, diabetes, metabolic syndromes, autoimmune. One of the most important risk factors is the obesity, and also coronary artery disease, vascular dysfunction, atrial fibrillation, and heart failure. So we have a GLP receptor one. It's produced from the intestine. It has a many effects in different organ. It helps the cardiovascular system by increasing the cardioprotection, increasing the glucose utilization, cardiac output, and vasodilation. They reduce fatty and metabolism, reducing the inflammation in the immune system, increasing the glucose uptake and perfusion, increasing the diuretic and natrices, and decreasing glucose production and cetosis, and increasing the lipolysis, and increasing the glucose uptake, and increase perfusion. It helps also in reducing the mortality and reducing the lipoprotein secretion. To reduce the gastric emptying, that's why patient always will feel that he's full, and they lose their appetite. And also, so what's terzapatide? Terzapatide is a new drugs that targeting two receptors, targeting glucagon-like peptide 1 and gastric inhibitory polypeptide receptors. Tirzepatide is dual agonist of GLP-1 and GIP receptors that appear to provide encouraging cardiovascular benefit beyond the glycemic control, and offering a potential a new therapeutic option for treating cardiovascular disease and heart failure. Tirzepatide is the first peptide, has a dual agonist effect, and it found that using in type 2 diabetes helping in the reducing hemoglobin A1C. So these medications, and when we use it in the type 2 diabetes, reduce the clinical outcome like the body weight, hemoglobin A1C, hemoglobin A1C, lipid profiles, and glucose adjusting glucagon secretion compared to typical glucagon like peptide GLP-1 receptor agonist. So tirzepatide helps in the heart failure patient by reducing the inflammation, autopathy, myocardial remodeling, and reducing and helping in the vasodilation, reducing in the atherosclerosis. So we have previous trial. They looked as using of semaglutide in a patient with heart failure with a preserved ejection fraction and obesity. Semaglutide is a GLP-1 receptor agonist and might only reduce the symptoms, but might also reduce the risk of major adverse outcome of the heart failure. These trials reduce by 8 to 9% in the body weight, that improve in the health status and exercise tolerance, and potential decrease in the risk of worsening heart failure. This is the first trial that was published last year. They looked at using of semaglutide in a patient with HFpEF, and semaglutide was 2.4 milligram, led to greater reduction in the symptoms and physical limitation and a greater improvement in the exercise function than placebo. So this trial was like multi-center and from multinationality, double-blinded, randomized, and compared to the placebo trial, control trial. It was a randomized trial, and they looked at whether the therapeutic of target the obesity in such patient HFpEF can help in the improving the symptoms and physical limitation. Patient characteristics always almost the same in both group. You can see here the like more than 50% are females in this trial, and also like from, as I say, like from multiple nationality, white including white people included 97%, black 8%, but no difference in both group. If we can see here the patient risk factor, AFib patients 50% and hypertension 82 or 81% in both group. History of CAD almost 20%. If in NYHA, most of the patient or majority of the patient classified as NYHA class 2, more than 60%. If we can like concentrate on the medication, more like 70% this patient are on diuretics, 70 and 82 on a placebo group, and using of ACE or ARNI also it was like 70%, beta blocker, SGLT inhibitor it was only 3% and 4%, because we can remember that at that time using of SGLT inhibitor it was not classified as a class 1A or a class 2A. So, but nowadays we use SGLT2 inhibitor in all patients with HFpEF. So the result over 52 weeks, we can see here there is improvement and improvement in the or changing in the KCCQ classification, and you can see early conversion of the curve and like in the beginning of the like after using it by one or second week. And changing in the body weight also there is a significant changes in the using and the group who used semaglutide compared to the placebo, and you can see here also early conversion of the curve, and then it continues to also to reduce in the weight. Here changing also in the case 6-minute walks, as we can see there is a significant difference between the both group, and statistically was significant also. And also changing in the CRP, it's better in a patient who used semaglutide compared with placebo. This is summary of the endpoints. The conclusion of that trial was in a patient with heart failure with a preserved ejection fraction and obesity. Treatment with semaglutide led to larger reduction in the symptoms and physical limitation, greater improvement in exercise function, and greater weight loss than a placebo. Then last month we have this trial using of terzapatide for heart failure with preserved ejection fraction and obesity, summit trial. The goal of that trial was to compare the safety and efficacy of terzapatide among a patient with a heart failure and preserved ejection fraction and obesity. As you said, like terzapatide is a dual receptor agonist, and with international trials, double blinding, randomized, and placebo-controlled trial. The randomized patient to 1-to-1 ratio to once weekly subcutaneous terzapatide and or matching placebo for 52 weeks. Randomized was stratified according to the body weight index, weight less than 35 or versus more than 35, history of heart failure decompensation within 12 months before the baseline, or history of type 2 diabetes, and dirazepatide treatment was initiated at a dose of low dose of 2.5 milligram once weekly, and the dose was escalated or up titrated every 4 weeks with the aim targeting maintenance dose of 15 milligram by week 20. So total screened of 1,400 patients, and total randomized participants was 731. Median duration of the follow-up was 104 weeks, a median age of 65 years, and they included more than 50% are female in this trial. And also this one different than, and also NYHA class was class in classification 3 to 4 was only 28%. They included patients who have diagnosis of stable heart failure with NYHA class 2 to 4, left ventricular ejection fraction more than or equal to 50%, elevated pro-BNP and anti-pro-BNP, and structured heart disease or elevated LV filling pressure. Estimated GFR should be less than 70 at screening, or heart failure decompensation within 12 months of screening. On stable doses of heart failure medication within 4 weeks of screening, BMI of more than 30, 6-minute walk distance between 100 to 425 meter, and KCCQ less than a score less than 80 or equal to 80. The excluded patient who had a major cardiovascular event within the last 90 days of screening, have had acute decompensation within 4 weeks of screening, have a non-cardiac cause of function impairment such as pulmonary arterial pressure, severe chronic COPD, anemia, thyroid disease, musculoskeletal disease, or orthopedic condition that can affect and also evaluation, and the presence of cardiac amyloidosis, cardiac combination disease like cardiomyocytes, myopathy, severe valvular disease, and uncontrolled diabetes with hemoglobin A1C more than or equal to 9.5, history of proliferative diabetic retinopathy or diabetic maculopathy, history of pancreatitis, GFR of less than 15, or requiring dialysis at screening. As I said, like here, patient characteristic almost the same in both group, female more than 50%, and from different, but included the white people more than 70%, and from North America it's only 7%, Asian 15 to 19%, and Black people from 6 to 3.8. Majority of the patient from Latin America, and the United States was only at 22%, included more than 70% of NYHA class 2 and 28% class 3 to 4. Body weight almost the same on both group, body mass also same. We can see here the risk factor, coronary heart disease is like 30% in both, and median NT-proBNP it's almost like 400, more than 400 in both group, or almost like maximum of 400. And also, and the other parameters also almost the same. And the using of, you can see here the use of diuretics, 70% of the both group, using of ARNI or ARBs, 80 to 80% in both group, and beta blockers 60%, and MRA it was only 36%, and SGLT2 inhibitor 19%. So the primary endpoint of cardiovascular death, worsening heart failure event for tirzapatide versus placebo was 9% versus 15% reduction, with the confidence interval of 0.4 to 0.9, with a p-value of 0.026. Cardiovascular death was reduction by 2.2 on terzapatide group versus placebo. Worsening heart failure event was reduced by 8% and therapeutic group versus 14% on the placebo group. Secondary outcome for tirzapatide versus placebo in all-cause mortality by 5.2% versus 4.1, changing in the KCCQ from the baseline to 52. It was like 19% versus the 12 percent, was statistically or significant. Changing the 6-minute walk from the baseline to 52 week 52 was also significantly statistically by like 26 reduction on the therapeutic group versus a placebo. And the changing of the blood pressure is not that significant, like only reduced by 4.6. Changing in the high sensitivity CRP from baseline, it was a really significant reduction by like 38% on the therapeutic group versus placebo. It was only 5.9. And changing the body weight between the baseline and the 52 weeks was 13% to 2.2. There's significant reduction in the body weight in the tirzapatide group. So a composite of the death from the cardiovascular cause or worsening heart failure, you can see here there's improvement in the in the tirzapatide group versus placebo, but the conversion of the curve was late after 24 weeks, and statistically it was like only p value of 0.26. But changing in the KCCQ score, it was significant improvement in the tirzapatide group versus placebo, and there is a really improvement in the early after using the effect. It was early after using this medication on in the first or second week. So the result of this trial showed that among obese patients with HFpEF, once weekly subcutaneous using of tirzapatide was superior to placebo in improving the body weight, and also in a patient-oriented quality like KCCQ and 6-minute walk test at 52 weeks. There is a reduction in the composite endpoint of the cardiovascular death and heart failure-related event was noted, primarily driven by reduction of heart failure event. And this landmark finding and concordant with the result of a STEP HFpEF trial with semaglutide. There is one limitation on this trial. That's about 17% only patients were on the SGLT2 inhibitor at the baseline. Although the guidelines was recommended using of the European and the American using SGLT2 inhibitor, it was like in the last year before publishing of this trial. And it was not unclear if the improvement in the outcome was driven by the body weight or like independent of this. So interesting observation that using and that high sensitivity CRP a marker for inflammation was reduced with tirzapatide, which could also represent a mechanism of its benefit of this medication. Thank you. I'm ready for any question.
Thank you very much, Dr. Nadia.
Yes.
Does anyone have any questions or comments on this presentation? Well, let me ask you a question first. Okay.
Yes.
This SUMMIT trial showed a reduction in heart failure events with terzapatide. Were the benefits consistent across the heart failure severity, for example, NIHR class 2 versus NIHR class 3 or 4?
Yeah, that's a good question. We know that NYHA, it's majority of these patients they were included in this trial were like NYHA class 2, and less it was like less than maybe 50, less than 30% were included class 3 to 4. And we can see if concentrate more on the results, it's like heart failure, hospitalization mainly that's driven the result. And majority of these patients, they will come, if in our practice, they will come with a volume overloaded, we give them diuresis and they will go home, if they have PEF patient, or controlling their risk factor. So I think that's not affecting majority of the because of the reduction in the weight and the volume. Maybe that's why it's improving in the NYHA, because NYHA, it's a clinical assessment by asking the patient about his daily activity. So to be honest with you, even I noticed in my practice, sometimes it's so difficult to assess the NYHA clearly with the patient. So once patient have even losing their weight, the NYHA classification will be improving. Yeah. So all like in the same, I think it's all in the same circuit. It's not related mainly to the heart failure with the preserved ejection fraction. I think it's related to the other risk factor, like the obesity, the metabolic thing.
Okay, thank you.
Okay.
Any other comments? Well, let me ask you another question. So given the significant improvement in quality of life and exercise tolerance observed in this trial, how do you see this drug role in management HFpEF, particularly in patients without obesity, but with visceral adiposity, so not patients without obesity? So is there any role of this drug?
We don't have still any like a trial can like we can be confident and say yes we can use it. But I try it because HFpEF, it's I say like as I said, it's had many risk factor. Maybe by reduction of this like the adipose tissue in the abdomen can improving their hemoglobin A1C, improving their activity, reducing the fat deposit. And we know that fat and atherosclerosis fat deposit in everywhere. Yeah. So I think by reduction in this and by reduction in the adiposity and or visceral obesity can help or improvement and the patient quality of life, like by reduction their like hospitalization or improving their function capacity, we can say it. So to be honest with you, I did not try it still with this patient. I use it with a patient who have some obesity, a BMI of more than 30. And I found there is a great result on that medication, even before publishing this trial, because at the beginning we know this step trial using of semaglutide, but unfortunately in our in our region the obesity it's really common. Yeah. And we have a lot of risk factor. So when I use this semaglutide, some people they will not lose weight, the bad responder we can say. So I used the terzapatide and I found a great effect by the reduction in the weight reduction and like improvement in their function capacity. So I say why not? It's less side effect. Yeah, the side effect of this medication only like GI symptoms. So I don't think there's any contraindication of fusing it and HFpEF patient without if we would use only like small doses. Yeah.
Okay. Thank you so much.
Okay.
Okay. So it's time to move on to the next speaker. Thank you so much. Well, can I start this my presentation?
Please.
Okay. Well, okay.
Yep.
Can you see my slide? Okay, thank you.
Yes. Okay.
Good afternoon, everybody. Thank you for joining this web seminar on early TAVR intervention in asymptomatic patient with severe AS. My name is Dr. Tomohiko Taniguchi. Thank you for inviting me as the JCS representative speaker in this APSC Cloud webinar. Today, we will explore whether early intervention or conservative management is the better approach for these patients, focusing on the recent trials, big trials, early TAVR and evolved. Let's begin. This is my disclosure. Well, to start, let's look at the management of asymptomatic patients with severe AS. For patients with preserved LVEF greater than or equal to 50%, the ACC/AHA guidelines generally recommend clinical surveillance every 6 to 12 months. But they also consider early intervention specific subgroups of patients, such as those with positive exercise stress test, very severe AS, elevated BNP levels, rapid progression, and or if LVEF is consistently below 60% on 3 serious studies. However, this approach, this watchful waiting strategy comes with challenges because symptom progression is unpredictable and the risk of sudden cardiac death, although low, but remains a concern. Well, observational studies such as the current AS registry have provided important insights into the natural history of asymptomatic patients with severe AS. The current AS registry, which enrolled 3,815 Japanese patients with severe AS during the TAVR era, is the largest cohort of its kind worldwide and has been extensively cited in the current ACC/AHA guidelines. This registry demonstrated significantly better outcomes in the initial AVR group, including lower rates of all-cause death and heart failure hospitalization. One notable finding was that in conservatively managed patients, those who developed symptoms such as class 3 or class 4 heart failure less frequently were not referred for TAVR, leading to worse clinical outcomes and higher mortality. These findings highlighted the limitations of a watchful waiting strategy and set the stage for randomized controlled trials like early TAVR and evolve trial. Well, before we discuss the rationale for early TAVR, let's compare the findings, recovery trial and Aperture trial. Well, both recovery and Aperture trials evaluated early surgical AVR, TAVR, in asymptomatic patients with severe AS. A recovery trial conducted in South Korea found that early TAVR reduced the incidence of the composite of the composite primary outcome, which included operator mortality or death from cardiovascular causes and during the follow-up period compared to conservative management. Similarly, Aperture trial conducted in Europe enrolled patients with preserved LVEF and severe AS and demonstrated a significant reduction in the composite of primary outcome, which included all-cause death, acute MI, stroke, or unplanned hospitalization for heart failure in the early intervention group compared to watchful waiting group. However, these trials primarily involved younger patients, 64 years old and 67 years old, which may limit the generalizability of their findings to older populations. Furthermore, both studies exclusively used TAVR, raising questions about their applicability in the TAVR era now. And in the Aperture trial, exercise test was performed in all patients, and bicuspid was included in 14%. But in the recovery trial, bicuspid aortic valve was included in 60%. And now let's dive into the study design of early TAVR and evolve trial. Early TAVR trial was a multi-center trial conducted in the US and Canada focusing on patients aged 65 years old and older with preserved LVEF and low surgical risk. A total of 901 patients were randomized 1-to-1 to either transfemoral TAVR or clinical surveillance. The primary endpoint was a composite of all-cause mortality, any stroke, or unplanned cardiovascular hospitalization. In early TAVR trial, unplanned cardiovascular hospitalization included TAVR that occurred within 6 months, within 6 months of randomization. This is a unique factor in the study design and driven by the sponsor's preference. An EVOLVE trial conducted in the UK and Australia specifically enrolled asymptomatic patients with severe AS and evidence of myocardial fibrosis confirmed by cardiac MRI like this. And the primary outcome was a composite of all-cause death or first unplanned AS hospitalization. Unplanned AS hospitalization was defined as unplanned admission before or after AVR with syncope, heart failure, chest pain, ventricular arrhythmia, or second or third degree heart block attributed aortic valve disease. And the mean age was 73 years old, and Vmax was 4.3 meters per second, and bicuspid was included in 30% of patients. Importantly, 30%, TAVR was performed in 75% of the patients, and while TAVR was used in 25%. Both trials aimed to determine if early intervention could improve clinical outcomes compared to watchful waiting strategy. And you can see the baseline characteristics in the early TAVR trial. Mean age was 76 years old, and STS score was 1.5. And importantly, in the early TAVR trial, a treadmill stress test was performed in 90%, and this is very high. And bicuspid valve was included only in 8%. And the Vmax was 4.3 meters per second, and AVF was 0.8 or 0.9, and LVEF was preserved. This is the primary endpoint. The primary endpoint of early TAVR was a composite of all-cause death, any stroke, or unplanned cardiovascular hospitalization. Over a median follow-up was 3.8 years. Early TAVR trial demonstrated a significant reduction in the primary endpoint compared to clinical surveillance, with a hazard ratio was 0.5. There was no significant reduction in all-cause death and stroke between the early TAVR strategy and clinical surveillance strategies. The incidence of unplanned cardiovascular hospitalization was significantly lower in the early TAVR group than in the clinical surveillance group. However, it's worth noting that 90% of patients in the clinical surveillance group underwent TAVR at 4 years. This is very high. And regarding clinical presentation at time of conversion to AVR among patients with the clinical surveillance strategy, advanced signs or symptoms or acute decompensation, the red sign, these symptoms, advanced signs or symptoms was present in about 40% of patients with conversion throughout the follow-up period. And you can see the death, the composite of death, stroke, or heart failure hospitalization. There is a significant reduction of these composite endpoint in the early TAVR group, than in the clinical surveillance group. On the other hand, the EVOLVE trial emphasized the prognostic role of myocardial fibrosis in guiding early intervention. This trial didn't demonstrate a significant reduction in all-cause mortality or unplanned AS-related hospitalization. But you can see the significant reduction in unplanned AS-related hospitalization. The hazard ratio was 0.37. These findings suggest that myocardial fibrosis could be a key factor in identifying patients who would benefit from early AVR. Well, what do these findings mean for clinical practice? A consistent observation across both early TAVR and EVOLVE trial was that early TAVR did not reduce overall mortality, but significantly reduced unplanned hospitalization. Additionally, even in asymptomatic patients, the majority of 80 or 90% required the TAVR within 4 years. This highlighted the progressive nature of severe AS and the inevitability of intervention, such as TAVR or SAVR. These findings suggest that careful risk stratification and timely intervention in asymptomatic patients with severe AS are crucial components in management these patients. Well, in conclusion, AS progression and symptoms expression are highly variable and unpredictable. And second, TAVR is acceptably safe. And additionally, even in asymptomatic patients with severe AS, intervention becomes inevitable for most within a few years. So careful, watchful waiting strategy is very important. And preemptive TAVR did not extend survival for patients who can be followed closely. And preemptive TAVR would be effective in reducing unplanned hospitalization. So these insights suggest that careful risk stratification and timely intervention is crucial. Further research is needed to validate these strategies in broader populations, including older population or very older populations. Thank you for your attention, and I'm happy to take any questions. Thank you. Is there any comment? Professor John Wang Chen. Okay, is there any comments or questions?
I think Dr. Chen is went to for emerging clinic. He left. He's not online.
Okay. Okay, so if you don't have any questions, do you have any questions? Okay.
Yeah.
Okay.
Your next speaker,
So,
Dr. Zhu, is online.
okay. Okay. So it's time to move on to the next presentation. So I would like to introduce the next speaker, Dr. Chen Yuan Chu. Okay, my pronunciation is correct.
Yes, thank you.
Okay, he is a assistant professor, Faculty of Medicine, College of Medicine, Kaohsiung Medical University in Taiwan. And his presentation title is Novel Coronary Implant, a Bioadaptor comparing to contemporary drug-eluting stents in complex coronary lesions, INFINITY-SWEDHEART trials. Leaving nothing behind. Implant is back. Okay, let's start.
Oh, thank you. I will share my screen. Can you see my screen?
Okay, I can see your slide.
Okay. Good afternoon, every colleagues. I'm Dr. Zhu, and today my topic is a presentation of the new clinical INFINITY-SWEDHEART clinical trial was announced in TCT 2024, and it can give us a new insight. Could leaving nothing behind, come back again. Okay, let's go to this my outline. I will explain what is Bioadaptor stent and the clinical trial result and the impact of leave nothing behind on clinical scenario. And I will give you everyone a small summary. Okay, this is what we call the Bioadaptor stent. It has 3 copochromium helical stent strata. It's a sinusoid in the appearance, and you can show in the 3 different color, and the head was connected temporarily together by a very unique uncaged element. It's this portion. So, and it was also covered by biosubtle polymer coating. So after 6 months, the biosubtle polymer will resolve, and then this stent will link and lock, and so the blood vessel biochemistry, the character will return near the normal vessel. This is also live from the Bioadaptor stent company. It can show us is the very thin strata, 3 helical sinusoid stent, axial connect at the longitudinal continuity, and the uncaged element at around 6 months later, because this PLLA biosubtle polymer will dissolve after 6 months. And then we'll show you the first in-man trial, Bioadaptor RCT trial. This is the international single-blind randomized control trial. Compares the limbus eluting Bioadaptor with a contemporary rotary limbus eluting stent in 34 hospitals in Europe, Japan, and New Zealand. You can see the clinical the setting. You can see after stenting, we will check the iris of the stent to sure the stent was well produced and well expanded. And after 6 months, the polymer will resolve and the stent will unlock. And then after around 6 or 12 months, we'll check the vessel image. Maybe use iris or OCT to check the component and the list burden and the result. Because the neohema formation and the helical stent was surrounded by smooth muscle prior to lock of the device, so the stent will expand and continue to provide dynamic support of the atherosclerotic vessel. This is the data of the total clinical trial. We can show at the 6 months in the non-inferiority setting, the stent and the traditional second generation DES, you can see the calculation failure was difference was 1%, so it's a match the non-inferiority. So it was similar in the efficacy. As for the component outcome, cardiovascular death, tachyvascular MI, clinical driven TLR, or defined or probable thrombosis, these 2 stents was comparable. However, we can see new diameter for lead lumen loss. We can check this at the 6 and even 12 months. We can see the new Bioadaptor stent have lower lumen loss. The value is 0.09. However, the traditional stent is 0.25. This is have a significant difference. 0.03A. Another, we see the neo-intimal hyperplasia inside the stent strut. We can see that the new Bioadaptor stent had a better result because they have less neo-intimal hyperplasia. However, for outside the strut, the neo-intimal hyperplasia is comparable. Also, we can see the cyclic pausality assessment used intravascular ultrasound. What is this meaning? Is we use the iris to check the lumen area before post procedure and the 12 months follow-up. Because this is the strut portion here. This is the proximal vessel without strut. This is a distal vessel without strut. We can see after the procedure, the two stents was comparable both in the non-strut area and the inside strut area. However, after 12 months, we can see that in the intra-strut area, we can see the Bioadaptor stent have a higher lumen change during cycle. It means it can move like a normal vessel. So compared to the non-stent area, the intra-strut portion, the vessel, the area change is compatible with the proximal portion. However, the traditional stent, you can see the lumen area change was lower compared to non-stent area. So this another evaluation tool, we use OCT at 12 months. We can see compared to the transdutional stent, the cyclic pausality assessment, we can see the Bioadaptor stent have better and a larger area change during cardiac cycle. So during this first RCT, compare the normal Bioadaptor stent with a contemporary drug-free stent, we can see that at 12 months, this new Bioadaptor stent had a better and a superior imaging endpoint, including restoration of vessel function. Based on this data presented in 2023, this year in EuroPCR, we can see this sub-analysis, because in the intra-stent portion, we can see the break after 12 months follow-up. We can see traditional stent, the post-procedure, and the 12 months, the change, the platelet burden, volume change is increased about around 12%. But however, during the after procedure, the Bioadaptor stent, the change of platelet volume is already 3%. Okay, we can see this is the inside strut portion. However, for non-stenting portion, the based on the imaging data, the two stent was comparable. And also, we can see the platelet volume change after a stenting for non-cardiac lesion. We can see the platelet volume was decreased with a Bioadaptor stent, however, increased with traditional DS. We can see the change. Another portion, you can see the lipid content lesion. We can also find the result. Even during the lipid content lesion, the platelet burden change was decreased with the new Bioadaptor stent, however, increased with the traditional DES. Conclusion from the data, we can see this new stent strut compared to the second generation DES, it was non-inferior. And also it provides better restoration of vessel motion and the function, and the restoration of in-device pausality with Bioadaptor data, lower left lumen loss, and lower percent of stenosis. And it's very thin and uniform neo-intimal coverage. And using this data, we can also see the plate was stable compared to the traditional stent inside the strut portion. And then we'll introduce the new INFINITY-SWEDHEART clinical trial. This was announced in TCT this year. We can see based on the data, we know that for the and the traditional first generation, second generation stent, we can see that after 12 months, the target lesion value was still increased. And the first generation and the second generation, the DS was comparable. And based on previous data, the bioabsorbable scaffold we call the BBS, leave nothing behind concept, was announced around about 10 years ago. But however, the long-term data was not so good because it has poor acute performance and the loss of long-term vasodynamic support during the scaffold resorption. And also after about 2 years, the BBS maybe show us 2 times higher in the stent thrombosis. And this new stent, Bioadaptor stent we have mentioned in the previous slide, we can see it's very uniform helical sinusoid stent strut, temporary connect with bioabsorbable polymer, and with bio unlock stent strut. We can see that during 6 months, this is locked, and it was a step flow on the lumen. After 6 months, the bioabsorbable polymer was resolved, and this stent was unlocked from each other. And after the 12 months, you can see the further increased restoration of pausality, compress, and adaptive coronary flow. Based on the previous Bioadaptor clinical trial, we can see the proposed procedure. The diameter was numerically smaller in the stenosis, and after 1 year in the QCA, we can see the new stent design have a lower percent of diameter stenosis. And also after 1 year, we use the IVUS to check the pausality. We can also see the restored pausality and adapt the coronary flow volume. This one is better in the due change of area, lumen area, and the pausality. Based on this data from the Bioadaptor RCT and this long-term second-year data was pronounced in the Euro PCR this here. We can see based on the 1 year and 12 data, 1 year and the 2 years data, we can see the Bioadaptor stent has lower and comparable target lumen failure at the 12 months. It was comparable. And also reduce and protein in target lesion failure and the target vessel failure through the 2 here. Because we can see the second generation DES, you can see after 1 year, the stent target lesion failure was increased slightly. However, with the new stent strut, Bioadaptor stent, we can see that even after 1 year to the second year, the TLF, the rate was plateau, also did not increase very sharply. And also based on previous mention, we can show that the new stent have a unique pausality and the intravascular imaging endpoint. The stent inside portion of most improved to the previous with stenting. So also normal finding, the plaque was stabilized and regress. So based on previous data, the INFINITY-SWEDHEART clinical trial can show us to compare the data between the 2 stents at the large clinical trial setting, and to see the primary endpoint include TLF at the 1 year and the power secondary endpoint. Then the power secondary endpoint use the superiority testing setting. We can landmark analyze for TLF, TBF, and the TLF in ACS from 6 months to end of follow-up. Okay, this clinical trials was conducted in Sweden. Okay, we can see the clinical inclusion criteria is age between 18 to maybe can also include CCS and ACS patient with PCI indication and successful treatment or prediatation of at least 1 target lesion. Maximum of 3 be treated up to 3 lesion or 2 target lesion with non-target lesion, and all was lesion should be treated with a suitable stent device. And inclusion criteria with a life expectancy less than 2 years, prior PCI, AMI with class 3 or 4, heart failure, first below 30, CKD, EGFR less than 30, or lesion involved lemon, venous bypass, instant stenosis, CTO, or lesion less than 3 mm from ostium. we can see the 12 months follow-up. This is about total about 2,400 patients in 20 sites was enrolled in this study, and during follow-up, the completion of rate of follow-up was 100%, and each site have around 1,200 patients. We can see the characteristic data of these two groups. We can see the lesion was inside the LAD. The lesion classification in the two groups was comparable based on complex lesion, bifurcation, calcified lesion, or tortuous lesion. And also we can see the lesion length is around 24. The diameter stenosis around 87%. The post-procedure, the diameter stenosis is about between 0.6 to 1%. And then we can see the endpoint. This is a non-inferiority setting. The margin of non-inferiority was 4.2%, and the setting, our setting, the difference was 0.40. So maybe this primary endpoint tells us these two devices was comparable in the non-inferiority setting. And also we can see the TLF and the stent thrombosis. The TLF we can see is comparable in non-inferiority setting. And also in the component outcome, we can see it's also comparable. And as for the stent thrombosis, these two groups was also comparable. And see the power, the second endpoint at 6 months. First, we can see the TLF. We can see the TLF at 6 months. We can see the Bioadaptor stent was here. The TLF, the rate was stationary. However, the DS was gradually increased after 6 months. And also we can see a TVF after 6 months. We can also find that the Bioadaptor stent was stationary after 6 months, but the traditional second generation DS was increased gradually. This both endpoint was significantly. And we also see the compare between the TLF prior within 6 months and after 6 months. We can see the p-value for intervention is 0.023. It means that these two groups was different. So after 6 months, we can see the superiority in TLF when used with Bioadaptor stent. Also see the subgroup data, like in the LAD lesions and the small vessel, we can see a better performance of Bioadaptor stent regarding the target lesion failure. For longer lesion, longer than 22 millimeter, the long rate p-value is 0.0453. So this is compatible. Also, we can see the subgroup analysis and compare with different components. For overall, we can see that the Bioadaptor stent is better. So in this conclusion, INFINITY-SWEDHEART is a large-scale multi-center clinical trial to compare a new stent-denied Bioadaptor stent versus traditional second generation stent. We can see the lower and the non-inferior TLF at 6 months and a scalar reduction in TLF, TVF, and a flatten of event curve after 6 months in favor of Bioadaptor stent. And also we can see that statistical clinical benefit for the high-risk subgroup, including acute coronary syndrome after 6 months. So this design, so we can see from about 45 years ago, we have only POBA, then we have bare metal first and second generation, and some unfavorable BBS result, and then now we have a new Bioadaptor stent, have a new stent design, and some good performance. As for the third part, we will mention the leave nothing behind, because it was aimed to reduce long-term device-related complication, ensure restoration of vessel function, and we have some key technology. The first is the BVS. The second is drug-coated balloon, and the third is the Bioadaptor stent. This is the three different design. For BVS, it's a temporary support with drug delivery, but the restoration of vessel nature is maybe within 2 years. However, the large profile and difficult in the procedure, and also have a lower radial strength. And there are some clinical trial and some longitudinal data show us that after 1 to 2 years, we have some scar for thrombosis, maybe early, maybe late. For CP was advantage is no permanent implant left in vessel, effective in instant with stenosis vessel, and the reduced risk of less than thrombosis. However, DCP is limited to specific lesion. Most should suit for non-calcified lesion, and no immediate vessel scar forming. So if the dissection after angioplasty is type C or higher, it was not suitable for DCP. And also the DCP require precise lesion preparation for effectiveness. Maybe we need a scoring balloon, cutting balloon, and some device, even for some debugging device is required. And for Bioadaptor stent, the advantage was combined feature rotational stent and the resorptor the scaffold, maintain radial force and adaptive velocity, and the potential for eventual degradation. Disadvantage is we have not so many long-term data. It's limited long-term data, and it was potential to encounter adaptation in complex lesion. So we still need more data, non-clinical trial, and some real-world research data to see the whole world of the Bioadaptor stent. So this is a comparative overview for BBS, DCP, and Bioadaptor stent. The key advantage is for BBS is restore function, and DCP is no permanent implant. Bioadaptor stent is adaptive and flexible. The limitation also the procedural complexity. DCP is limited lesion pre-application, and the Bioadaptor stent was some in early clinical stage, so need more data. So for further duration, for BBS, maybe should have some material innovation to improve strength and reduce thrombosis risk and enhance deploy technique. For DCP, we have some expanding indication and lesion comparability, deliver new drug formula, and for Bioadaptor stent, we need a long-term clinical trial data to ensure safety and efficacy, and refine the design for composite lesion. Final slide. Evidence from large-scale INFINITY-SWEDHEART clinical trial confirmed result from the Bioadaptor PCR RCT trial and suggests that the Bioadaptor stent may represent for a long-term awaiting solution to flatten the event curve following PCI, making a significant advancement. And the reason behind approach is transforming PCI. Each technology has a unique strength and limitation. Further research should focus on optimized outcome and expanding indication. And finally, the patient-centered decision-making is the key. This is my presentation. Thank you.
Thank you. Thank you very much for your excellent presentation. Does anyone have any questions or comments? Well, let me ask you a question first. Well, this trial reported favorable outcomes for patients with ACS and other high-risk subgroups. Could you explain the potential mechanism in these subgroup benefits?
You mean the ACS subgroup benefit?
Yeah.
Yes, because it's what maybe we should see what's your competitor for drug routine stent. In the acute phase, we have a good radial force and support, but in the late phase, we have impaired the lumen loss, and we lost some vessel motion and the vessel passability. This may be the reason why between the two stents, the Bioadaptor stent may be better, because after 6 months, the passability of the vessel was improved. And with your competitor was the drug coating balloon. The most problem because in the acute coronary syndrome, we have maybe 80% of the acute coronary syndrome was from plaque rupture. At that portion, the thrombosis and the thrombogenicity may be higher. So for DCP, you should choose less thrombosis lesion for DCP treatment for acute coronary syndrome. However, we use a Bioadaptor stent, we can combine the benefit of DCB and the DES. So maybe it's a alternative choice, I think.
Thank you. And your presentation is a result at 12 months.
Yes.
And as the study continues for 5 years or 10 years.
We will have some long-term data. Maybe this large scale. Maybe have later follow up for the Bioadaptor stent. We have 3 months data. So, but that RCT was only 400 patients. For this one is 2,400. So the volume was different. So maybe we are waiting for the data later in the clinic.
Long-term follow-up.
Yes, yes.
So what results or improvement would you expect to see in the Bioadaptor stent compared to current dried aortic stents?
I think for this, maybe we have some better muscle motor function, I think. And also maybe for better motor function, maybe we can see better muscle remodeling. Maybe we have seen that for after acute coronary syndrome, or maybe for some coronary syndrome, we can see the vessel to increase in his diameter for the downstream portion. And then maybe for upstream portion, we may see that some vessel we have is conformity to compare with the original coronary structure. Because we have some standing, that you can see some in right coronary artery. You can see after standing, the anatomy was totally changed, was different. But I think the Bioadaptor stent, after 6 months, the stent structure will unlock. So each portion will have a suitable performance and a suitable position. It's maybe can give us a better result.
I see. Okay. Any other comments or questions from audience? Okay. Okay. So thank you for excellent presentation, Dr. Chan. You're sure. Thank you.
Thank you.
Well, so I would like to closing session. Thank you very much to all our speakers for their insightful presentations, and to everyone who joined us today. We have explored cutting-edge topics in medicine, from GLP-1 and stent and aortic stenosis and CETP inhibitor and lipoprotein little a. Very interesting topic. And I encourage each of you to take today's knowledge forward into your practice and research. Thank you once again, and I look forward to seeing you all at future events. Have a great day. Thank you.